Hi everyone, I'm Dr Clarke and welcome back. Today we're covering treatment-resistant depression, or TRD for short. This is a very common CASC station and one you need to know inside and out if you want to stand out and secure that excellent pass mark. Examiners aren't just looking for you to reel off a drug list or treatment pathway. They want to see clear, structured explanations that take a holistic biopsychosocial approach, show empathy and instill hope, helping the patient feel confident in both their treatment and in you as their psychiatrist. In this video, I'll walk you step by step through how to do that. From taking a focused history to framing the diagnosis and then explaining safe, evidence-based next steps. By the end of this video, you'll have a clear blueprint for scoring top marks in a TRD station and feeling confident in your exam.
You are asked to review Mr. David Harris, a 42-year-old man who has had a depressive episode for 9 months and has been under the care of his GP. He has trialled several antidepressants at adequate doses, sertraline, escitalopram and now mirtazapine, and he has also tried CBT but with minimal improvement. Please take a history to evaluate for treatment-resistant depression and discuss potential next steps in management.
Hi David, thank you for coming in today. My name is Dr Clarke and I'm one of the psychiatrists. I understand you've been feeling low for quite some time despite trying several treatments. Today I'd like to ask you a few questions about how you've been, clarify the treatments you've already tried, and then discuss the next best steps we can take together in order to help you feel better as soon as possible. How does that sound?
This opening creates a great first impression. It sets the agenda with confidence and builds good rapport from the beginning, whilst also instilling hope in future treatment in a patient who is likely feeling quite hopeless after 9 months of trying different treatments already to no avail. Ask about mood, anagia, anhedonia, sleep, appetite and concentration.
When did these low feelings start? Have they been with you most days since then? How is this affecting you day to day? For example, what's your energy like? Are you managing to still do your usual activities? Are there any activities which you used to enjoy that don't give you any pleasure anymore? How has your sleep been? Do you find you wake up much earlier than you'd like, or that you're waking up throughout the night? And how about your appetite and weight? Have you noticed any changes there? How's your concentration been? For example, when you're reading a book or watching TV, can you usually follow the storyline, or do you lose track?
Give the patient plenty of time to answer. You do not want to rush a patient presenting with depression, and follow up gently on any cues, for example, days spent in bed or stopping hobbies. Remember that psychomotor retardation is common in depression, so slow your pace and keep your tone warm and supportive, allowing extra time for responses. Avoid compound questions as well. Ask one question at a time so that the patient can process and respond fully. Clarify adequacy and criteria for meeting TRD, meaning 2 or more antidepressant treatments at adequate doses for sufficient timeframes.
I understand you've tried several antidepressants. Could you tell me which ones you've tried, roughly what doses you were on, and for how long? Were you able to take them regularly? And did you notice any side effects? I understand that you also tried CBT. How did you find it? Were you able to learn any useful skills and complete the homework tasks set by your therapist?
Confirm they took sertraline, then venlafaxine, then mirtazapine, each for several months at good doses with good adherence, but minimal benefit. Check CBT was attempted, but with low success and engagement.
Have you ever had times of feeling unusually high, with lots of energy and less need for sleep? Have you had any blood tests done recently to check your thyroid function and blood vitamin levels? Because you've been feeling so low, I do need to ask, have you had any thoughts about harming yourself or ending your life?
If positive, explore intent, plans, means, timeline and protective factors.
Have you made any plans or taken any steps to act on those thoughts? Thank you. To summarise what I've heard so far, you've had a prolonged severe episode of low mood lasting for about 9 months, and you've also had at least 2 adequate antidepressant trials as well as CBT. These have not provided enough benefit for you, so we'd now describe this as treatment-resistant depression. This just means that the initial treatments for depression haven't helped enough, but there are still loads of evidence-based options that we can try together.
Remember to chunk and check all explanations and allow the patient time to respond.
There are 3 main areas we can consider as part of your treatment: medication strategies, psychological approaches, and practical or social supports. I'll outline each now briefly, and we can discuss in more detail any options you think you'd prefer.
Offer NICE-aligned evidence-based steps and remember to discuss augmentation, antidepressant class switch and ECT.
One well-supported option is to add a second medication to your current antidepressant. This can really help to boost its effectiveness and its response. The best evidence is for adding lithium, although sometimes we add low doses of antipsychotics or combine 2 different types of antidepressants, like venlafaxine and mirtazapine. Combining medications like this can really help when single antidepressants haven't worked. Another approach is to switch to a completely different class of antidepressant. And in cases of severe or life-threatening depression, ECT is still a very effective option. It can work quickly when other options have not helped, and it's offered in specialist settings with close monitoring. Would you like me to explain any of these in more detail now? Some of these options do need extra monitoring to make sure we keep you safe throughout your treatment. For example, if we choose to start lithium, we'll check your kidneys and thyroid function and regularly monitor your lithium levels through blood tests. Alternatively, if we add an antipsychotic, we'll keep an eye on things like blood pressure, weight, blood sugars and cholesterol levels. Before starting anything new, I'll go through the possible side effects and the monitoring plan with you, so you feel fully informed about the treatment you are starting. Does that sound okay to you? I know blood tests can sometimes feel like extra hassle and they're really uncomfortable, but I want to reassure you, we wouldn't start any medications without first explaining the monitoring to you and making sure you're happy with it. We'll also do our best to arrange things in a way that fits your lifestyle. Alongside medications, therapy remains really important. If CBT was too hard when your energy was really low, we could consider a different type of therapy like interpersonal therapy. Or we could return to CBT, but with very small structured steps so that it's more manageable for you. We'll also work on practical measures to help you, like improving your sleep routine, introducing gentle physical activity, organising your daily structure and involving your partner or workplace for extra support where you agree it could be useful. These small changes can make a big difference alongside medications and therapy. In summary, you now meet the criteria for treatment-resistant depression after multiple adequate medication trials. Reasonable next steps include adding lithium or a low-dose antipsychotic, switching antidepressant class, or trialling ECT. We'll also consider a different therapy approach and practical supports for your sleep and activities. If you're happy, I'll arrange a further appointment to decide which option to start and set up the necessary monitoring for you. I'll also give you written information about all the options we discussed today, so that you can have a think about what treatment might be best suited to you before our next appointment. Do you have any further questions? Thank you. I know this station can feel really overwhelming, especially if the patient presents as severely depressed and slow to respond. Don't panic. The examiner mainly wants to see that you can communicate clearly, explain how TRD is diagnosed, and outline safe, evidence-based next steps. If you jump into treatments too early or speak too quickly, you risk opening up a list of options like TMS, deep brain stimulation, or thyroid hormone augmentation, which really isn't necessary to score the top marks. Thanks for watching. If you found this video useful for your revision, then please do give it a like, subscribe to my channel, and drop a comment down below. I'm happy to answer any questions, and I'd love to hear which CASC topics you'd like me to cover next. Stay tuned for my next video, where I'll be covering how to explain Lewy body dementia to a concerned relative. And of course, I'll help you feel confident in passing that station too.